Good day, dear great surgeon. We now gonna talk about the surgical technique chapter. It's very important for every surgeon, whatever your specialty, and it's overlapping with many chapters because the surgical technique is within each and every specialty in surgery. So let's crack this chapter together, and together we can, with the grace of God. Methods of wound closure and management of burn. One of the main crucial pillar topics in every exam. There will be no MRCS exam without asking you about the wound closure technique or even the burn technique and the burn equation. So, regarding any wound or any burn, the critical size we are talking about, the cut of the size, it will be 1 centimeter. Below or smaller than 1 centimeter cube, you can deal with this wound without any um, big deal. Like there is no need for grafting or even local flap is not needed. Just if it was a scratch, go and cover it. If it was a wound, go for simple suturing. But if we are talking about skin loss more than 1 centimeter, we are thinking here about our options and go for reconstruction ladder from secondary to primary to secondary to grafting and flapping according to the tool you can use at this area. And by the way, when to use split thickness graft and full thickness graft. A simple rule that the split thickness graft has a feature that it has no much primary contraction, unlike the full thickness graft will have a primary contraction. It will be smaller in size. For example, if you harvested a full thickness graft with the whole derms and the whole epithelium, it will be on table about 3 centimeter, for example, or 5 centimeter. But on the patient, it will contract and shrink out. This is the primary contraction. This feature happens with the full thickness graft and doesn't occur with the split thickness graft. So by logic, the split thickness graft, which is apart from the epithelium with no derms at all, has less elastin and will has no primary contraction or very less primary contraction than the full thickness, but it will cover more area. And this can be meshed or even bi-crusted, where you put holes within this skin graft and you can spread it all over the body in every place. And by the way, when you use split thickness graft, it will give you a wide range, but it has bad cosmesis. That's why split thickness graft is not recommended in the face. So again, when you have a superficial wound, will re-epithelialize within 48 hours maximum if it's less than 1 centimeter, and you can applicate a simple dressing and it will go heal without grafting or flapping or any of the plastic hocus pocus magic tricks. By the way, you can always have an option called delayed primary closure. When some patient come to you in the ER with a dirty wound, you can do the primary survey and you can do your first aid by cleaning and debriding the wound without any closure. The only exception for this rule will be the scalp. But also can be applied on the delayed primary closure, where you irrigate the wound and debride the wound and devitalized tissue are removed. You can always go for primary closure with the scalp, but you can also use the delayed primary closure if you found the wound is still dirty. But a very famous record regarding a dirty wound in the scalp: go for removal and excision of this wound and debridement of the deepitalized and devitalized tissue, and go for primary closure only in the scalp because it's highly vascular, and the face to some extent. But the delayed primary closure is the best choice in a dirty wound. It's the similar methods of the primary closure but we have a dirty wound. So you do debridement, irrigation, and do the same techniques you used in the primary closure on the clean situation, but later on when you are sure that your wound is clean. If you are not familiar with the word flap and graft, Flap is a viable tissue with a blood supply, with an actual blood vessel. Either it's pedicled or free, where you cut off the blood supply and come with this vessel and replant and re-anastomose it to a new vessel. This is a flap. Or axial flap, where it's a random axial flap with a known blood vessel at this area or unknown blood vessel in this area, but following the rule that it has a blood supply already connected with the blood, the surrounding tissue. While the graft, you taking the whole organ, the skin is an organ by the way, you take the skin without any blood supply, and it will depend on imbibition and inosculation for its blood supply. So a very famous rectal question about an abdomen with crust on it. This crust resembles the third-degree burn, which taking the whole thickness of the skin. This must be debrided. After the debridement, would you put a split thickness or full thickness or a flap? Third-degree burn in the abdomen requires a wide range, a big surface area, wide surface area. We can't waste our full thickness graft over the abdomen. So go for split thickness graft, and better to be measured to cover the whole surface area. A very famous recall question about a patient who got his nose cut off by a dog. A dog bit his nose and the nose now become lost. What to do? Take care. This question is tricky because at the time of incidence, we are fearing that the dog gave the patient rabies. So you will be delaying this repair because the definitive nose reconstruction will be with forehead pedicled flap or even prefabricated flap. So the solution for nose reconstruction will be flap. But take care. This patient has been bitten by the dog. I am fearing that the patient can get rabies from this dog. Give this patient debridement and excision of the wound and cover it and go for continuous dressing. Give this patient rabies, anti-rabies, and give the patient anti-tetanus and follow up. After the patient got recovery and you are fearing no infection from the wound, go for the reconstruction of the nose. So at the incidence, we are debridement. There is no immediate reconstruction after nose bitten by a dog. We are feeling the dog, not the nose reconstruction. I'm sure you all can do nasal reconstruction because we are all surgeons. But of course, I am a plastic surgeon. I can do it better. Hope it made it clear. By the way, there is another trick I want to tell you about burn and tissue coverage. Regarding the burn, we are fearing of the fluid loss more than the devitalized tissue because more fluid loss will cause more devitalization and necrosis of the tissue. A second degree burn can go to be third degree burn just by tissue loss by dehydration and fluid loss. Our skin is not only cosmetic, it's a functional unit, a functional organ to protect your fluid and protect your heat. And you will lose your heat and become heated by the burn effect and lose your fluid, and this will make a second degree scald burn to be a full thickness third degree burn. So take care. At the time of the incident of the burn, yes, we are caring for the wound, but first resuscitate the patient and give him fluid replacement. That's why MRCS exam, I hat off for this exam putting technique, the examinee. The examiners are putting in every exam an equation for the burn to make you aware and sure that the burn fluid replacement is more important than the coverage. And it will save the patient from being from second to third. Even it can make the patient go from second degree to first degree and improve more rapidly. Someone asked me what is the defabricated flap. It's a prefabricated, not a defabricated. The prefabricated it's a previous than the operation, where the nose contains cartilage, bone, and skin. If you lost your nose, you will need a prefabrication. You will need a nose, has skin, has bone, has cartilage. So we take a rib and implant it below our arm or below our abdomen according to the flap you are going to use later on, as a free flap, of course, like the radial forearm flap, very famous to be used as a prefabricated flap for the nose reconstruction. Then you go and implant it later on. So you go for implanting and harvesting the cartilage and the bone and implant it in the arm of the patient and do a full nose job in the arm of the patient, and then take this nose later on after 3 weeks and implant it in the face of the patient. Hope this made the prefabricated flap point clear. But this is a too sophisticated plastic surgery question. The question will be direct to reconstruct or not reconstruction. He will ask you about using a flap or not using a flap, and the more trick, it will be a local flap or a free flap, not the name of the flap or the technicalities of it. My parents taught me to ask once and know it for all. Never be embarrassed to ask. Ask and gain knowledge. If nobody asks, there is no knowledge to be added. So, a very great question to ask. What is meshing of the graft? The graft is a sheet of skin like a sheet of paper. When you put holes with your scalpel within this graft, this is called a crust pie, just like a pie coming out of the oven, and you do crust and bit holes within the graft to cut the elastin fibers in within the skin exoskeleton to make this graft more malleable and give it more space. There is a machine called a mesher to make it like a meshed, that it will spread more, like the mesh you use for hernia. Yes, it spread more, it will give it more wide space. The bit holes within the sheet of the graft will make it more elastic and more wider and give you more space to use. Hope this made it clear. Of course, to do a graft, you have to have a healthy bed of granulation tissue, bright red like a meat, so you can graft on it. So the graft can take its blood supply by impupation and insufflation. So, if you put this graft, after about a week, you will find a thin bluish white margin appear around the graft and spread at the rate of 1 milli per day. What is this? This is an epidermis. It's the process of re-epithelialization. So, it seems that grafting is a pretty everyday routine for a plastic surgeon. So why don't we use it for every wound? Take care. We have a rule called reconstruction ladder, and we are looking for the cosmesis of the skin as well as the function. To gain the best cosmesis out of plastic surgery or closure technique, you have to have a like tissue, a skin for a skin from the same area without any donor side morbidity. The graft is good to cover a wide area, but it has a brutal, unsatisfactory donor side morbidity because you take this graft from another side. From the side you take the graft, it will be morbid and not feeling pretty well. So you have two scars, not only one. So better if you can do a direct primary closure when it's feasible, go for it. And take care from the timing of removal of the sutures of your suturing and your closure, because they can take place and make a snail track or a train track like appearance in the wound, and it's ugly scar from just leaving the wound with each suture for more than it takes. So go for direct primary closure when it's feasible, like a grown man with a tissue defect measuring about 3 centimeters for 1 centimeter following an excision of lipoma. It's a clean wound, a clean surgical operation. Why to go with a flap? It's simple. It's 1 centimeter wide. Of course, go for direct primary closure. It's more, if it's more 1 centimeter, go for undermining or even a local flap after trying undermining if it's not can be approximated. Most of the skin can be approximated by undermining, but take care never take your suture under tension. It will make an ugly scar. Make it your least option. There is always a local flap can be done. So if it's 3 centimeter by 1 centimeter, you have 1 centimeter gapping, you can always go for direct primary closure, especially in a clean surgical operation. Yes, you are totally correct. If it's a clean operation, go for closure, but in abscess or infected sebaceous cyst, never close. The trick in the exam will be in the sebaceous cyst. If it's a clean sebaceous cyst, go for inoculation of the sebaceous cyst and close it primary. But if it's effective and it will call you, it will have an offensive odor or it's tender. There is no tenderness in sebaceous cyst. The pit in the sebaceous cyst is the closed sebatium and sebum enclosed within. There is no pain. If it's painful or tender, so it's infected. If it's offensive odor, so it's infected. It has a yellow discharge, it's infected. It's pus. So there is no closure in removal of infected sebaceous cyst. Deal with it as an abscess, and no one closes over an abscess. A very challenging case will face you in real life and in practice and in the exam is regarding the diabetic foot management. You have to follow a protocol. Take care and keep up with me. The diabetic foot is not only a local problem. He had a generalized problem and local problem. And the local problem is not within the tissue itself as a skin only, because he has microangiopathy and microneuropathy and neuropathic pain, as well as we have an ulcer that is resistant for treatment because it's contaminated with sugar, which is eating and feeding the whole bacteria. It's like making a carnival for the bacteria to eat within the diabetic patient foot. So we need to make sure that there is a blood supply going to the foot. Most of the diabetic patient will be having a comorbidity with atherosclerosis due to microangiopathy and hypertension, which might be associated with this patient. So take care. Is this patient have ischemic limb or not? So in a diabetic foot, go for duplex to ensure that there is a blood supply going to the limb, and do an x-ray to make sure that there is osteomyelitis in the patient or not. It may be hidden and you don't know. Don't make sure of osteomyelitis without investigating for it. And by the way, in MRCS and in real life, the x-ray osteomyelitis means this patient is neglected, but the earliest sign for osteomyelitis appear in MRI. Take care. So we now know that the vascular supply is good and know that the patient has no osteomyelitis. Go for dealing with the wound. The wound will be dirty, will require debridement. After debridement, what to do? How to cover the leg of the patient? You can always go for a flap, which will not be dependent for the bed of the patient as long as it's good. But the patient is atherosclerotic and ischemic. You can't put the flap here. So we want to graft it and cover it. But we need for coverage with a graft and healthy granulation tissue. How can we obtain a healthy granulation tissue earlier and faster? Go for vacuum assisted closure system. The use of the vacuum assisted closure device has been shown to improve the healing rate and time. It will save time and give the patient a plenty of granulation tissue. So using negative pressure therapy, which is a vac therapy or vacuum assisted closure, will facilitate the wound closure. There is a sponge is inserted within the wound cavity, and then negative pressure is applied according to the setting settled by the technician or the plastic surgeon following up, or the diabetic foot doctor specialist. The advantage will include removal of exudate. It's like a very instantaneous, every 5 minutes cleaning of the wound from the exudate, and it's pushing the tissue to form a granulation tissue, a healthy granulation tissue. You will find the wound red like a meat after the back therapy within a week. What you can do it with normal dressing in months, it can be done within weeks with the vacuum therapy. By the way, The free flaps are now the mainstay for coverage as long as you can do it and it's feasible, but it requires a facilitation or a facility which is prepared with microsurgery. Until then, go for back assisted closure and then do your grafting. And if the patient is contraindicated to do a major operation like the free flap, go for the vac therapy and closure with the grafting. Whenever you need a bedding for the graft, go for the vac because the continuous dressing will be exhausting on the patient and costly. By the way, the vac therapy is widely used in Egypt and many countries. It's very available. You have to know about it. This is the whole trick. And again, vac therapy is not magic. You have to be sure that there is a blood supply reaching this limb. You have to be sure that there is no osteomyelitis or no impending infection below. Yes, it will go and remove every exudate from this wound, but it will be more improving and more usage of the advantage of the vac therapy if its wound is clean. By the way, the vac therapy can be used for the burst abdomen. We will talk about the burst abdomen and the option for closure. So, from the very famous options for burst abdomen closure will be the vac assisted closure. And even in presence of abdominal fistula with a colonic or intestinal fistula, you can put it on a low pressure vac therapy to close this fistula. There was a big debate about it. If you are general surgeon, you must be aware of it. And regarding the burst abdomen, of course, you can always put a Bogota bag for the burst abdomen, just like we done for the gastric cases, or take a zipper or a tension suture to make sure that the tension is lessened for the burst abdomen and make sure there is no infection or source of infection, and go for the closure option for the burst abdomen. I like the composite question in MRCS, like a very famous question about local anesthesia preparation, asking you what preparation will you use in a Zadix procedure. So he is asking here about the anesthesia you use and its concentration, as well as he is asking you about the Zadix procedure. The Zadix procedure is a procedure done for the ingrown toenail. So he is asking you about the local anesthesia technique used for a finger operation or a toe operation. So we all know that the ingrown toenail procedure will be Zadix procedure. So what anesthesia you will use? What is the concentration you will use? The trick in MRCS that they follow the strict technique without adrenaline. And by the way, nowadays we can use adrenaline, but take care, in UK they don't use it. In Wallon technique we use adrenaline as long as with lignocaine, but in UK they don't use it. So forget this idea and know it for yourself. So regarding the SADX procedure, what anesthesia we can use? We can use the ring block with 1% lignocaine, and take care because in the most preparation in our practice we find it 2% lignocaine. But in SADX procedure, 1% lignocaine alone will be sufficient, and the anesthesia will be in ring block. And by the way, the lignocaine antidote if toxicity occur will be intralipid injection. Great. By the way, the UK don't use the adrenaline for fear of ischemia because of course it can cause ischemic reaction and cause gangrene. And by the way, the fingers are a little bit important for some people. By the way, from the very famous blocks, the Pierre block, which is using the Prilocaine. Remember, it's less cardiotoxic than the lidocaine, but take care, the Prilocaine can also cause problems. So if any toxicity caused by the Prilocaine or you want to reverse it, you can always use the methylene blue. Take care, this great surgeon. I know we all use lidocaine in our practice, but take care because this local anesthetic now it's less commonly used and antiarrhythmic because it affects the sodium channel in the axon. This is a mode of action, and it has a hepatic metabolism and protein bound and renally excreted, but this is not the problem. Due to IV or excess administration increase risk of liver dysfunction or low protein state. It can cause acidosis, called lidocaine to detach from the protein binding, and it has an interactions with the beta blocker and ciprofloxacin and phenytoin. So take care if the patient on beta blocker or a cardiac patient or an old patient, make it a rule. If an old patient, take care from the toxicity level regarding the lidocaine. Remember, it's 3 milligram per kilogram and calculate it. And the features of toxicity: initial CNS overactivities in depression, and lidocaine initially blocks the inhibitory pathway, then blocks both inhibitory and activating the pathway, and it will cause cardiac arrhythmia. Take care. Toxicity by lidocaine is very critical. There will be a metallic taste and metallic sensation in the patient mouth and tongue, and will feel his mouth numb. Take care. This is lidocaine. Remind me of the metallic taste by the caused by the flagell. The metronidazole causes this metallic taste, by the way, but in lidocaine it means toxicity, not normal thing. If you want to have a more dose, an extended dose, an increased dose from lidocaine, you can almost use the adrenaline, and it will give you the benefit of the adrenaline and make your operation bloodless. But take care, again, the lidocaine toxicity maximum dose will be 3 milligram per kilogram, and if you added adrenaline, use 7 milligram per kilogram. So again, the adrenaline might be added to local anesthetic drug and prolong the duration of the action of the lidocaine at the injection site and permit the usage of higher doses. We all know that lidocaine uses only 3 milligram per kilogram per kg. So in addition of adrenaline to the lidocaine, you can add up to 7 milligram per kilogram, and it's high. It's like the doubling of the dose by using and adding the adrenaline, and will give you the benefit that it will be vasoconstricted and bloodless operation. But take care, because adrenaline is contraindicated in the patient taking the MAO or tricyclic antidepressant. The toxicity of the bupivacaine is related to the protein binding, and addition of adrenaline to this drug doesn't permit the increase to the total dose of the bupivacaine. So adrenaline can be added to the lidocaine and increase the dose of the lidocaine. But in the bupivacaine, it can't increase the dose of the bupivacaine, and the bupivacaine maximum dose will be 10 milligram per kilogram only. Clear? This great surgeon, take care. Previously, cocaine was used as an local anesthetic purposes as a paste, but I doubt any of you would recommend it anymore for his patient unless he want to make his patient high. Regarding the surgical technique, take care from the preparation of your operating room, and take care from every little detail, because everything matters. You want the patient on fire, not literally on fire like burning the patient, but make the patient on fire from the surgical accuracy. But making the patient in actual fire, this is not acceptable at all. He is a human being. Nobody wants to be fired. So take care. In bipolar unit, the flow of electricity is from one electrode to other over a small area. So this is not catastrophic like the diathermy, and there is no diathermy associated in a burn injuries that can occur with bipolar. Bipolar has less much incidence with burn injury compared to the diathermy. But doesn't mean that the bipolar can't cause burns, because the bipolar can cause fire if it's near an alcoholic-based skin preparation. I know you can do sterilization of the skin by povidone iodine. It's safe with the bipolar and diathermy. Chlorhexidine is safe with bipolar or diathermy, but not alcohol. Alcohol is not safe at all to be used either with bipolar or either with diathermy. And of course, it's contraindicated with diathermy, and nobody use it with bipolar. Nobody use alcohol beside bipolar, or you will literally make your patient on fire. So please don't burn your patient. Give him a fire service. Don't fire him, don't put him on fire. This may result from a careless handling of the devices, or in the case of the monopillar devices, forgetting to apply a return electrode plate. In this situation, the patient may develop a contact burn when electricity flow to the earth. So take care. If you smell like a meat burning inside the operating room, they are not doing a barbecue in the operating room. It's prohibited. So it's most probably it's a barbecue of your patient. These great surgeon, you can always decrease the surgical site infection by taking care of the preoperative and intraoperative as well as the post-operative preparation. So take care. During the preoperative state, don't remove body hair routinely. This is important thing. And by the way, in every operative file, you will find a preoperative statement by the nurse and the head nurse to fill it and file it with the patient and the doctor to make sure that the item have been filled, like even the bodily hair, is it removed or not. So don't remove the body hair routinely, and if a hair requires to be removed, use the electrical clipper with a single used disposable razor, because the razor increase the infection risk. So use the electrical clipper with the single use disposable clipper, not the razor. The razor increase the infection risk because it makes a micro laceration in the patient's skin, and this will increase the infection. Use the antibiotic prophylaxis before the operation if the patient is having a placement of prosthetic or a valve, if he's having a prosthesis or a valve, like hip replacement, knee replacement, or even the aesthetic surgery where the doctor giving the patient to put an implant. Give the patient antibiotic prophylaxis if it's a clean contaminated surgery or a contaminated surgery. Use a local formulary always, and aim to give a single dose of IV antibiotic on anesthesia on induction. And if a tourniquet is to be used, give prophylactic antibiotic earlier. This is regarding the preoperative preparation to decrease the surgical site infection. Intraoperative, you have to prepare the skin of the patient with the alcoholic chlorhexidine. It has lower incidence of surgical site infection than the povidone iodine. So povidone iodine is used and alcoholic chlorhexidine is used, but take care with alcoholic chlorhexidine. Don't burn your patient again, please, please. And cover the surgical site infection with a dressing. Some use the opsite if it's available, but it's a little bit expensive and costly. The opsite used over the skin to cover it and make the skin flora don't enter within the new wound you are creating with your scalpel. A recent meta-analysis had confirmed that the administration of supplementary oxygen doesn't reduce the risk of wound infection, in contrast to previous individual random controlled studies. But take care. The oxygen intraoperative, we are not here talking about the hyperbaric oxygen. Don't confuse the hyperbaric oxygen with the oxygen, because the hyperbaric oxygen increases the viability of the wound and the devitalized tissue to be removed and give the wound health care a very, very promising care. And many studies talked about the hyperbaric oxygen. We are not talking here about a simple oxygen. So intraoperative, the use of oxygen doesn't reduce the risk of wound infection. This is all a randomized controlled studies. Take care. A meta-analysis is number one level of evidence. So a meta-analysis called that oxygen doesn't reduce, so it's level one evidence. So intraoperative, prepare your skin with alcoholic chlorhexidine, which has lower incidence of infection than the povidone iodine, and of course cover the surgical site with dressing, which is draping your patient, and wound edge protectors doesn't appear to interfere any benefit. A very famous question: does the use of diathermy for skin incision is advised? In NICE guidelines, the use of diathermy for skin incision is not advocated, and several randomized controlled trials have been undertaken and demonstrated no increase in the surgical risk of site infection when diathermy is used. But for me, I use the scalpel because it makes the skin incision more neat to cover. If we are talking regarding surgical site infection, there is no difference with the diathermy or not. But if you want to make a better cosmesis, use the scalpel. It's my own preference. So according to NICE guideline, there is no difference. The diathermy for skin incision is not advocated by the NICE guidelines and not advocated by me. In those items we have talked about, we have placed some basics for the incidence and the lovely chapter, the stats. We all love the statistics and the evidence. So meta-analysis is level 1 evidence, and it's the best evidence to be done. Better than Bishoy saying his own technique. He is saying his level 5 evidence, which is the experience only advice. Make sure that you use the meta-analysis and meta-studies because this is the highest level of evidence in your practice. Please, great surgeon, take care what mode of diathermy you are using during each operation. For example, during the ERCP sphincterotomy. During sphincterotomy in ERCP, always use the monopolar diathermy device in cutting mode. And this cutting monopolar mode is needed. However, that's why it can complicate the ERCP with bleeding. And this can cause even a transmetic pancreatitis, which can be caused by the ERCP. So you have to be aware of the ERCP. It's using the monopolar diathermy, so be cautious during your manipulation with the ERCP and make sure you are using it correctly. And of course, during brain tumors, we are using the COSA device. Remember the COSA device for the brain. Our brain is filled with COSA. If you are Egyptian, you will get it. What is the ligature and the ultrasound-based devices? The ultrasound-based devices include the COSA and the harmonic scalpel. They generate a high-frequency oscillation that seal and coagulate tissue. They have different energy setting that allows them to dissect and simultaneously seal vessels if required. So it dissect and simultaneously seal. This is the future, by the way, the COSA device and the ultrasound-based device. But they are a little bit costly. So the COSA device leaves a vessel intact that may then be divided. And that's why it's used in the brain tumors. Regarding the ligature device, it delivers tailored energy level to allow simultaneous hemostasis and dissection at the same time. The device senses the impending of the tissue and tailors energy level accordingly. And almost always you have to take care of the hazard can be caused by the diathermy, either the monopolar or the bipolar. Of course, most of the plastic surgeons requires precise by the bipolar. Even they use now the needle, not only the bipolar. And the bipolar is the electric current flow from one electrode to another. However, both electrodes are usually contained within the same device, a pair of forceps. It's like a forceps. Yes, شياكة حاجة كده, very stylish to use a bipolar. The result is that heating is localized to an area between the two electrodes and surrounding tissue damage is minimized, while the monopolar, which is used for example in the ERCP and many general surgeons tend to use a monopolar, the current flow through the diathermy into a handled device in the surgery hand, and this controlled by the surgeon, by the way. The electricity can flow from the tip of the device into the patient, and the earth electrode is located some distance away. The relatively narrow tip of the diathermy produce local heat, and this can be used to vaporize and vargulate the tissue according to the need. The current can be adjusted in terms of frequency so that the different action can be affected. In cutting mode, sufficient power is applied to the tissue to vaporize. Again, cutting mode is vaporizing the water content. In coagulation mode is reduced, the power level is reduced, and you are targeting the coagulum to be formed instead. So in coagulant mode, you are forming coagulation, but in cutting mode, you are targeting vaporization. Some diathermy machine can utilize a setting known as blending mode that alternate between the cutting and coagulation, cutting and coagulation. That's why it's blending. These tend to be used during procedures such as colonoscopic bulbectomy. And by the way, during using of monopolar diathermy, take care if the patient having a prosthetic pacemaker or not. So we are all now familiar that the electrosurgery is a term to describe roughly the diathermy modes. Electrosurgery utilizes the heat generated by the passage of a high frequency alternating electrical current through the living tissue. The application of the voltage across the human tissue results in the formation of electrical circuit between the voltage source and the tissue. The tissue acts as a resistor, and the level of resistance is determined by the water content of the tissue, and this is the whole trick. It is the resistance that results in the formation of the heat. An alternating current constantly changes the direction in which the current flows. The speed with which that occurs is measured in hertz. Most diathermy units operate in frequency between 200,000 kilohertz to 5 million hertz. So, this means that the tissue such as nerve, muscle will not depolarize, since this seldom occurs at frequencies above 10,000 hertz. The current waveform can be adjusted to deliver three main therapeutic modalities: cutting, coagulation, and blending. This whole annoying long talk about electrosurgery is no use. You don't need anything from the whole previous talk. The last 2 minutes, forget them. And focus on the types of the current. We have the cutting, coagulation, desiccation, fulguration, and blending. Let's finish from the blending. Blending is alternating current between the cutting and coagulation. The total average power is less than with the cutting. So it's less, but it's alternating. The question in the exam will ask you, what is the blending mode directly? You have to know it's alternating between the cutting and coagulation. But the trick in the exam, if it came regarding the type of the current, what is the cutting, what is the coagulation? The cutting will be causing, yes, sinusoidal and non-modulating waveform, high average power, current density, and precise cutting without thermal damage. There is no thermal damage in the cutting. This is the whole trick. That's the cutting without thermal damage. What the coagulation will cause a thermal damage, will cause evaporation, while the cutting will cause vaporization. Again, remember, we have talked about it before. Coagulation will cause evaporation, not vaporization. But the cutting will cause vaporization, cut vap, co-evap. So the coagulation will cause evaporation and will cause coagulum. What is the desiccation and fulguration? Here is another trick. The desiccation is the active electrode in direct contact with the tissue. The dissect is direct, while the fulgurate is away. The fulguration probe is held away from the tissue. This is the whole trick. Now let's have a glimpse over a very important topic in MRCS, the sterilization. Sterilization is not cleaning only. It's not only disinfection. Sterilization is a whole different type of cleaning, because cleaning refers to only removal of the physical debris, and disinfection refers only to reduction of the number of viable organisms. So to be precise, during your intraoperative cleaning of the patient, you are doing disinfection. Sterilization is removal of all organisms and spores. I doubt this is done intraoperative anywhere. So we are doing disinfection. So it's disinfection, draping and toweling, not sterilization. Take care. So sterilization is different according to the item you want to sterilize. According to the item you want to sterilize, you will use a different method. We have many methods to do sterilization, like autoclaving, glutaraldehyde solution, or ethylene oxide, or gamma irradiation. I believe the patient can't be entering the autoclave to be sterilized because he will need some air, and it's a little bit hot in there within the autoclave. So don't sterilize your patient. Disinfection will be enough. Autoclaving, it's air removed and high pressure steam used where about 134 Celsius for 3 minutes. Don't make barbecue out of patient, and it's only indicated for the reusable surgical equipment. Most be physically cleaned prior to autoclaving, unsuitable for fragile items. You can't use some plastics in autoclaving, it will melt, but you can always use a metal equipment. But if you have an endoscope or laparoscopic items, how to use a sterilization method for it? You can always use the glutaraldehyde solution. It's a colorless oily liquid, directly cyticidal and virucidal even at low temperature. So glutaraldehyde solution is the best method to sterilize your endoscope or laparoscope. Someone asked me how to sterilize the Backend material, like the syringe, like the cannulas, like even the suturing material, how to sterilize them. You can almost always use the ethylene oxide. It's a 3% mixture of gas and carbon dioxide used to pack material that cannot be heated. The gas is explosive and environmentally toxic. Take care. It's used mainly in the industrial material. For patchy treatment or relatively thermostable items, we can almost use the gamma irradiation. Gamma rays emitted from radioactive substances such as cobalt-60 or cesium-137. This can be suitable for the patchy treatment or relatively thermostable items, or even the operating room. If you are in a fancy hospital, we can use the gamma radiation or the ultraviolet radiation. So sterilization is removal of all organisms and the spores, while disinfection refers to reduction in the number of the viable organisms. So let's have a practical example. We have an instrument used to drain a tubercle bacilli from a cold abscess, which is not an abscess and it's not cold. It's composed of caseous material, which is full of tubercle bacilli. The tubercle bacilli has a waxy outer membrane that renders it more resistant to sterilization and cleaning methods. Whilst the sodium hydrochloride will destroy many microbes, it's less reliable to destroy the tubercle bacilli. So we can't use the chlorhexidine either, and the iodine is not enough. Even the heating oven, it can be used. So you can almost always use the autoclaving to destroy the tubercle bacilli. So hot air ovens provide less reliable pathogen destruction than autoclaving. If you have autoclaving, go for it. Don't be classic with the heat oven. Use the autoclaving. But take care, they might be indicating in situation where the equipment is sensitive to autoclaving process. From all of the options we mentioned, autoclaving will be the most reliably to destroy the tubercle bacilli. So happy to have been with you today. Until we meet again, together we can. Looking forward to hear from you, and may God bless you with wisdom, peace, strength, and joyful success. You are such a great team, dear great surgeons. A very nice question regarding an old lady with basal cell carcinoma excised from her right cheek. There is a rhomboid defect measuring 4 by 4 centimeter. What is the best option for managing this wound? Let's see the choices and think together. Delayed primary closure. There is no need for delayed primary closure for basal cell carcinoma. You have to cover it. Direct primary closure. 4 by 4 centimeter. It can't be closed primary. It will be under tension and ugly scar. Local rotational flap. It's a great option. Split thickness graft. There is no split thickness graft used in the face. Pedicled mycutaneous flap. It will be overrated. 4 by 4 centimeter, just skin, pedicle mycocutaneous flap, it's overrated. So from the options we have here, the local rotational flap. The only confusion if we have the option of full thickness graft, but always go with the reconstruction ladder. Whenever a local flap is feasible, go for it, because like tissue will be better cosmetic. So go for local rotational flap as long as it can be done, especially in the face where we are looking for a cosmetic result. Another trick for coverage is regarding the burn. If you are not a plastic surgeon and you haven't faced many burn cases, it might be tricky in the exam using the term crustaceans, or even telling you that there is a fixed pigmentation affected area with white and dry appearance. All of those terms are denoting a third-degree burn. So the best management will be, of course, debridement and grafting, and taking the decision of the type of the graft according to the site. If we are talking about the face, better to be with a flap or a full thickness graft. But in the torso or the abdomen or the chest or the leg or the limbs or everywhere with 20% per, we are talking about a large surface area. How can you get a full thickness graft with a large surface area like 20% or even 5%? Go for split thickness graft, because with this there will be a better fast take of the graft, and there will be a less donor site morbidity, and the patient will be healing more fast, and of course will give you a wide surface area. Hope those made it clear. Until we meet again.